My role within Amgen, and Amgen is a biotechnology company that develops medication, mainly in cardiovascular, oncology, osteoporosis, and some other diseases. My role as a real data manager is that I help my colleagues to get insights in what's happening currently in especially the Netherlands. My focus area is the Netherlands. What is happening in healthcare, how patients are treated currently, and what our medication is adding to that. And that's really important in order to get reimbursement for our therapies. So I will quickly today walk through the development of drugs and how medication is developed, in which stages, and what challenges we face there. Go a little bit into the challenges in healthcare in general, and then focus on the challenges we have in getting reimbursement. After that, I will go more into depth in the role of data and how I think that will change the future of healthcare. We already heard quite a lot of very nice examples. I've here a little bit. I've here some numbers from the Netherlands. This is from the Dutch Cancer Institute. They collect data of oncology diagnosis in the Netherlands for over 30 years. They also keep the survival of patients, and what you see here is that in 30 years' time, the 5-year survival of patients is increased from 50% to 70%. So that's already, I think, a great example. If you look to cardiovascular diseases, you see here patients that having that die from a stroke, for an heart infarct, for an MI. You see that it is going down with more than 80%. So we are great in developing new therapies, not only medications, but also interventions, surgeries. We are doing quite a lot in that. But it's a hassle. You can see here, for general medication, we start with over 8,000 candidates, 8,000 possible medications or ideas to develop a medication. We bring that back in research. We do quite a lot, and AI is helping definitely in that. Large data sets, all the developments with biobanks, they are really helping to become quicker and quicker in reducing the number of candidates, leading up to a few potential medications. But then we have all the clinical studies, of course, that need to be followed, which takes 4 years. And earlier today I heard about 12 years. It's also what's saying here. Some drugs take over 20 years to come from the first IDs till a validated medication. Sometimes a little bit quicker, but it takes very, very long. Then we have, especially in the Netherlands, but all the other countries have more similar kind of processes, the Dutch reimbursement process. It's already complex if you see this overview, but to be honest, it never goes as you expect that it should go. Most likely, in most cases, there's always sometimes a change of regulation, for example. There are new insights, there is a lack of data, or there's a lot of discussions on the reimbursement. At this moment, it takes on average 600 days in the Netherlands to get a new drug reimbursed. So after EMA approval in Europe, we can file a dossier to get reimbursement, and it takes 600 days before we have reimbursement. It's almost 2 years. That's a real issue, and in that time the drug is not available for patients, at least not in the reimbursed or the insured system. Those discussions are difficult, and of course also we understand that. This is a picture again from the Netherlands is the amount of money that we spend in the Netherlands on healthcare. And there are quite some discussions in that. Of course, you see that it is growing over time, and with each change in the political climate, some things are put into the insured healthcare, and sometimes some things are getting out. We are reducing the amount of money that hospitals have available. So that's why you see all the bumps in here. And there is a big difference between those two lines. And the big difference, the dark blue line, is the international definition of healthcare. But in the Netherlands, we also like to do much more around that. So if you are disabled, you also get reimbursed for having somebody to clean your house, for example, or to help you with all kinds of things. If you need help, you can get help to shower or things like that. That's not in the international definition, but you can see that costs a lot of money. So that's are very difficult discussions. How long can we afford us to do that? Especially if you look to this picture. We have seen it before in other presentations. So in other countries, this issue is the same. In 2020, 1 in 7 employees in the Netherlands were working in healthcare. At this moment in time, 2023, is already 1 in 6, and in 2040, we expect that it is 1 in 4. That if we continue in the way that we are working now, 1 in 4 employees need to work in healthcare to deliver the care as we have it right now. That's not feasible. We have to do other things as well. And the problem is getting bigger. It's getting bigger every year, every medication that is developed. We already discussed it quite a lot. We're coming to much more targeted therapies. So where in the past a therapy was available or applicable for all lung cancer patients, we are now looking to patients with a very specific target. And of course, the larger targets has been selected first. So then we are talking, well, at least in the Netherlands, about thousands of patients. We are now bringing for lung cancer, for example, a drug on the market for 300 patients per year. But one of the next therapies that we are currently having in a phase 3 trial, that are only 30 patients per year in the Netherlands. The development cost, they are almost the same. So you can see that will definitely give some really big challenges. And we need to balance all the costs that we have, everything that we want. There are costs for hospitals. We, of course, need to pay the nurses, physicians, the devices, medication, innovation. There's so much that we want to do, but it all should be in balance with the outcome for patients. And therefore, one of the big challenges that we see at Amgen is the reimbursement process. This is what the reimbursement in general buckets was in the last few years. So after the EMA approval, we started negotiations with the Dutch government. We get reimbursement for our products. Then we have to go to hospitals, to the physicians, and make sure that our products become part of the guidelines and become a part of the protocols in hospitals. Physicians start to prescribe the drug. That brought us a volume, and that volume was our sales, our turnover. But things are changing. The clinical studies we have been doing, they are not enough anymore. So what we see now in quite a lot of our indication areas is that we get, after very heavy negotiations of multiple years, we get access to the market, but only temporarily. We have to prove in a few years that our drugs add the value that we promised. that means something. That means that we also are responsible for where drugs are used, for which patients they are used. That also means that we have to really follow up on that. And more importantly, that means a lot of uncertainty, and even more because we see that now in the first cases that the volume that we had in the past is not directly leading anymore to sales. We see more and more that we are being paid for outcomes, and that only the real world outcomes that that patients reach, that are the things that are being reimbursed. So we are getting a broader responsibility. We are getting that together with the physicians, with the hospitals, and for most of our drugs, not only with one physician in one hospital, but with multiple physicians, often in multiple organizations. And that is a very, very challenging part. Especially as I tried to show a schematic overview of the data collection in the Dutch healthcare. I heard in other countries that's not very structured over there as well. In here, in the inner circle, that are the locations where data is collected, and it are now 6 or 7 organizations, looks like, but every of these buckets collect of 70 hospitals, about 5,000 GP offices, about 2,000 pharmacies, and many more. So data is scattered on very many locations. The circle around it are registrations. All kind of organizations are trying to combine the data of the different organizations, collect it, and see what they can find out. Most of the time, they don't collect data of all healthcare providers, but only from a small part. Quite often, there are multiple registrations in the same indication area using different definitions and different intersections of the Dutch healthcare landscape, ending up with different results on the question that you ask them. Then there are many companies around that trying to sell the data for a lot of money, and patients and physicians, they have no clue where the data is or how it is used. So hopefully the GDPR has already started to structure that a little bit. We hope that the European health data space is bringing a little bit more structure in that as well, because data is the real issue at this moment. It's limited available, and that's due to a few things that already passed today's presentations quite often. But it's very difficult to collect data. There are a few physicians here. During your discussions with the patient, you don't want to be putting too much attention to the computer. Then there is data coming in from a laboratory and maybe from multiple laboratories, and before all that data is collected in a structured way in your system, that's a very hard thing to do. And to give you a little example, the Dutch Cancer Registry, the data, the graph I showed in the first slide, they have 150 data managers around the Netherlands. And to put that in perspective, that we have about 70 hospitals. So that's more than 2 data managers per hospital to collect data of the cancer patients. And then we are only collecting data on the indication of the patient and the first line of treatment. So we don't collect anything about the long-term follow-up and the second line or third line treatment of patients. There are many different sources. I already said something earlier, but we have the physicians in the hospital, we have the GP offices, the pharmacies, and in only the Netherlands there are over 100 registrations. There are different goals for data collection. So the clinical research is an important source, of course, but also collecting data for reimbursement or collecting data for actually treating the patient. It gives different type of data, different things that you need, and that's difficult to combine later on. And it also gives a very high cost for collection. And there's also always a discussion who is the one who should pay for collecting that data. And together with that, we already discussed a few times today patient-reported outcomes, but they are only very limited collected at this moment in time. And if you want to collect them, you should use them as well. And that's a very difficult process to make sure that you collect sufficient data to actually be able to use it. And then we have the access of data. So as an industry in the Netherlands, we see these issues, and we try to help together with many other organizations in the Netherlands to bring up some ideas how we can push things forward. And one of the main elements that we have is that the patient should be in the center of it. So he shouldn't be in the lead. I don't really believe in ownership of data, but we should organize things around the patient. So that means that the patient at least should have access to the data of all the different care providers. You should be able to call to your hospital, or better, log in and get some information back on what they know about you. And preferably it should be in an understandable format as well. The same goes for the health insurance companies. That might be even the most easy information, because it is one of the sole sources that is really structured. It's used for reimbursement. Patients should be able to add their own data. We already discussed quite a lot today, but many people are walking with smartwatch, and at least everybody with a smartphone. Patients should have insight in who is looking in their patient files. They should know who is requesting data of them, and their data should be correctly pseudonymized or maybe anonymized to make sure that's also used for secondary use. And that data can be used for much different purposes. So, for example, research, make sure that there become outcome-based payments, or care improvement projects. There is a lot possible, but it all starts with data. And a few of the important things together with all pharmaceutical companies in the trade association, we set up 10 steps we think are very important. I won't go by all of them, but a few I would like to highlight. So I think it's very important to have one nationwide system, at least one system per indication. Another important thing is that it should connect to more European standards as well. And hopefully the European health data space again is helping in that. It should be indication focused. What we have seen in the Netherlands the last few years is that many of these registries are based, for example, only on one medication or one type of treatment. But you should not only compare, for example, heart surgery with heart surgery. You also should compare heart surgery with the minimal invasive surgeries. And also compare it with medication treatment or doing nothing at all. If you really want to see what the added value is of your therapy, you should focus on indications. We should try to create a single source data collection. So that means that if a physician is writing down things in his medical record, that should be sufficient and should be standardized enough to be used after that as well. So the 150 data managers that for the National Cancer Registration are looking into all those patient files, you shouldn't they shouldn't be there that are in most cases nurses that really understand what is in the patient files. But if you are collecting data structured, and then that might not be necessary. You can directly use and reuse the information, and that's where we should go to. And we can only do that if we use standard definitions. That should be in a system that is paid from general resources. Quite often we hear in the Netherlands as well, pharmaceutical industry, medtech industry, you want to use this data, so you should pay for the data collection. I'm happy to pay to access the data, but I would really like to prevent that industry is the ones who's paying for the data collection, because if we will pay for that, we also are the one who decides what to collect. And I don't think that should be with industry. That should be with physicians, with the physicians associations. They should decide what is important to collect, and they should be the owners of that data sets as well. Everybody who wants to use it, if you want to create an AI model, if you want to develop medication, and you want to use the data, then you should pay. In the Netherlands, we are having quite some nice initiatives, I think. The first one is really patient-centered. We're trying to, there is now a law obligating each healthcare provider to give a digital access to patients to their medical information. So if you go to a hospital, there should be a place where you can log in and request all the data they have from you. I think that's a really great start because that makes each healthcare provider think on how to register the data, how to make it available, and how to standardize it. There are, there is a Health Research Institute, an organization who got a big grant by the government that is working on getting all that data also available for secondary use. So now we're talking about the grounds in the GDPR, how you should be able to use that. How can you connect the data over different healthcare organizations? And in the meantime, there are some smaller hospital organizations. So Santion Group consists of 7 hospitals around the Netherlands. They set up with all international standards their own data infrastructure. Currently, it's one database on single location, but they are ready for future developments, for federated learning, for federated analysis. The same is the academic hospitals. They try to do that as well. So there's a lot of initiatives that try to grow. The challenge is now to align those initiatives within the Netherlands, and also to align it with other European countries, because we also like as the Netherlands to be seen as very innovative and far ahead of the troops, but there are other countries that have these kind of things much better organized, and we should learn from that and make sure that we can align with those initiatives as well. And if we do that right, there is a great future ahead of us. It's also called the fourth industrial revolution. We already heard quite some nice examples here, and I definitely see that around. If you look in hospitals, there are quite a lot of nice initiatives. I really like the development around the Internet of Things. For example, the smart bandage. You put on some smart monitor, small wearable, and it measures all the important signs. Many patients, they are in the hospital just waiting to have something done or something seen in the monitor. And in the meantime, they're just lying in a bed, waiting until the physician walks by. And that can be different. They did a research in a university hospital in Nijmegen, and they asked patients at the emergency department, would you like to go home if we can monitor you at home correctly? 90% of the patients said, well, if possible, yes, please, let me go home and I will come back tomorrow if the physician is in-house and we can have a solid discussion on what's wrong with me. 10% liked to be in the hospital, and mainly because they didn't have the facilities at home or nobody at home to help them with anything. And if we do that correctly, we might end up with the healthcare of the future. This is a picture of Frits Kahn. It's created in 1926. I think it shows a great future that we have ahead. A physician that is monitoring patients all around the world in any location. You can look to ECGs, to all kind of things while you're just smoking your cigarette behind your desk. So who knows where we end up? I think the main important element there is that we should collect data in the real world. So don't talk that much anymore about clinical trials, but talk about the clinical trial we have the entire day when treating patients. Thank you.